Good afternoon to you all. I'm Jagdish Hiremat. Well, I'm here because I'm brother of Dr. M.S. Hiremat. So
that's not true, Jagdish.
we have a young man around 45 years, a chronic smoker, non-diabetic. He had an anterior wall MI almost 8 years ago. That time no angiogram was done on him, and he was treated as he had chronic left ventricular dysfunction and was being treated as into quotes ischemic cardiomyopathy. About 4 months back, he presented outside hospital with congestive cardiac failure. And when he was investigated, he was found to have a patent left system, that means recanalized left anterior descending artery. And he had a chronic total occlusion of the dominant right coronary artery. So we had a situation wherein the anterior wall was probably non-viable and a chronic total occlusion of the right coronary artery. The echo showed a left ventricular ejection fraction of about 25%. He underwent a resting thallium viability, which showed a non-viable anterior wall and viability in the inferior wall. With this, he was taken up for a right coronary artery angioplasty.
Marco, whilst he's setting up the slides, what percentage of your angiographic procedures would show up CTO?
I mean, of the diagnostic angiogram?
Of the diagnostic angiogram.
I don't have the number in my top of my head.
Roughly.
Roughly, I would say 10-15%.
What about you, Samir? Yeah. Let's see.
We've gone through these slides. So anterior wall MI 8 years ago. I'll show you some pictures. He had this ECG which showed right bundle branch block with left anterior hemiblock and a full PR interval, old anteroseptal MI. And his echo showed a thin akinetic anterior wall with LV ejection fraction of 25%. The thallium shows clearly a non-viable anterior wall and some amount of viability in the inferior wall. His coronary angiogram showed a patent left system and a CT of the RCA. I think these are not my slides. I think we'll have to change the presentation, Suma. So Kunal? Yeah. Okay. Go to the previous one, please. Okay, show this one again. You can see the left system is a big heart, and there is tachycardia. Next, please. The left system looks reasonably okay. Next, please. And it shows the right, play this again. Right coronary shows a chronic total occlusion of the artery. At this stage, actually, he was taken up for angioplasty in an outside hospital. Next, please. Next. You can see that an Amplatz guide is used. Next. And the attempts to cross this lesion failed. They've used some 4 wires. The last one was a Shinobi, and it could not cross the lesion at all. There is a mention of balloon support being used, but we could make it out on the films. Next, please. Go back one slide. Yeah, play that. This is the last slide where he was left with a totally occluded artery. Next, please. And the patient worsened and presented to us at this stage with a closed right artery in marked congestive heart failure. He was decongested for 5 days and taken up for angioplasty of the right coronary artery. Next presentation.
Jagdish, you're not going to show how you treat it.
Yeah, we just show the first slide,
Okay.
how we got the artery now. Now,
Yeah,
play
okay.
this, please. No, there is one more presentation. Next CD, please. Okay, we can stop at that and start discussing. It was the same as we saw the last one. So we have a large heart, LV ejection fraction low, and attempted angioplasty of the right coronary artery, which is now completely closed. That is where now we can open the case for discussion.
Okay. First, I think you will say how would you have treated this case?
Yeah, I just, forgive me for I don't have any presentation because I am seeing this for the first time. I just would like to ask you a couple of questions before I can make up my mind. Yeah. The thallium was obviously done before the angioplasty attempt.
Yes, true.
Right? And is there any worsening of the infero-posterior wall on the echo now after the PTC attempt?
I would say that, no.
No.
I don't think he
and
infarcted
were the
in the
enzymes elevated after the attempt?
No, they were not checked.
Okay. Fine. Okay. So, and the patient had worsening of his CCF.
That's right. He presented to us with a worsened heart failure.
And did not have much angina, but it was more of
that's right, heart failure.
Okay, so clearly the questions would be whether this patient needs a repeat attempt at angioplasty or not. His renal functions were not impaired.
That's right. He had normal renal functions.
Yeah, so I would say, assuming that since his echo did not show any worsening of the wall motion abnormality, and hopefully the enzymes were not very significantly elevated and he didn't have a scar, so he merited another attempt at angioplasty.
Yes.
Now the second question would be, to my mind, what would be the best time to attempt this angioplasty? It was only 5 days after the first attempt, and should we allow the dissection to heal for a few more days and then attempt, or should we attempt right now? That, I think, in my practice would entirely depend on the patient's clinical status. If the patient is not doing well and patient is unstable, I would still, I would go ahead and do the angioplasty at this stage. But if the patient was not that unstable, I would wait for a few days more, allow the dissections to heal, and then attempt. That's my practice. And the third question would be, if we go ahead with the angioplasty, what kind of hardware we would use. I am not sure why the Amplatz was used in the first place in the previous attempt, but presumably because they did not get enough support in wiring the lesion, and that's why the guiding catheter was used as an Amplatz.
They started with the Amplatz.
Okay, so then I would use a routine Judkin catheter to begin with, even in this case. and then think of changing the guiding catheter. The guide wire, to me, would be any intermediate wire, preferably Asahi one. I would not like to use, to begin with, I would not like to use hydrophilic wires because the presence of dissections and flaps, which would be there from the previous attempt. And I think that's it. And I would not use any upstream 2B3A or anything until I cross the lesion. I would use heparin also in a minimum dosage, just to allow us to wire the lesion. Is there anything?
So in this case, actually, from before the attempt, let's say, I think there was some hope, should have been some hope for wiring this lesion through microchannels with wire like filter wire, and also I would have started in a more softer way with 7 French, but JR4. But I assume they have attempted this and then they switched to an Amplatz. Now the situation is much more complex because, and you said it now is completely occluded, the vessel.
Yes, it's completely.
Yeah.
When you took up,
Yeah,
there was
it
total
was.
occlusion.
Yeah, it's almost more than hardly any trickle of flow. I'll show that once we
There's
start.
just one question.
Yes, sir.
In the patient, when they attempted,
Yeah.
I could see that there was ipsilateral filling of the right coronary artery,
Yeah.
was filling ipsilaterally. Whether through the bridging collaterals or with a central microchannel, I don't know. No way to say. And suddenly, I could not see any collaterals coming from the contralateral vessel.
No, there were no collateral from
And
the
yet,
contralateral.
when it got totally occluded, he did not go into a cardiovascular hemodynamics collapse. Like he went only in CCF.
That's right.
And that too, he for 4 or 5 days, he maintained his hemodynamics and then came to you. Is a little surprising, won't you say
He
so?
was hardly a blood pressure of 90 systolic.
Uh-huh.
So it was, he did suffer. I mean, he was not totally stable when he came to us first. After stabilizing with medication, he came to a stage where he could be taken up on the table and we could attempt it.
Yeah. And I think in the first place, it looked like more like recanalized occlusion with, at this time, I would have hoped for microchannels.
Yeah.
And would
But
have gone ahead with
unfortunately-
a softer or
So that
hydrophilic
means,
wire,
no, not softer, but polymer wire.
polymer wire.
Exactly. The other question is the worsening of the heart failure? I agree with Dr. What was previous said, that is the worsening of heart failure due to the procedure itself? We know was used a lot of dye, was a long procedure, and we can assume that there was some kind of relationship. If yes, then I would also support the idea of postponing a little bit the procedure. If not, then we are forced to go. But
Our concern
Less
was
is-
that he had an open artery when they took him off for at least it was flowing when they took him off for angioplasty, and then it got closed. So we thought, try and open it as that's the only chance he has.
Chronic total and acute closure of the forward flow
Yes.
completely. And yet he had the viability present there.
No, this viability
some
was checked
hibernation.
before. This viability was checked before the angioplasty was attempted.
No,
I
but you
agree.
did say that echo did not show any worsening of wall motion.
no,
So,
no.
and the muscle in the infraposterior
Yeah,
wall was still
muscle
the
thickness was
still
definitely
there.
maintained. Yes.
and he didn't have an MI, obviously. He didn't have a raise
The
of enzyme.
possibility that I can think is that when there is a ipsilateral collaterals and viability maintained by ipsilateral collaterals present in a totally occluded RCA, when it closes and yet the viability is shown or maintained, probably collaterals from the contralateral side recruited. That's the only thing that comes to my mind. But you are going to spell the surprise now.
No, not much of a surprise. I thought the discussion would be more on the technique of this.
Okay. You
Can we
want
have
to,
the next CD, please?
Yeah. Just to Samir Dani, I think. Marco, about the technique, he's asking if there are any
Yes. So in this case,
strategies.
yeah, in this case, obviously, since there is no good contralateral collateral, so would be again a second approach from the same side. At this point of time, I think that we will be forced to go with an aggressive guiding catheter. So with the first morphology, I would have tried something less aggressive. With this one, I guess that we are forced again to go with an Amplatz guiding catheter, probably AL1, probably depending on the size of the aorta. And then I would try once again with polymer wire, with filter wire and microcatheter, hopefully to go through it. Otherwise, then we have to switch gear and to go something more aggressive. Of course, in this case, no to be the receptor inhibitors. But following the first, let's say, procedure, the success rate now, and I'm sure you will show success, the success rate now has fairly decreased compared to the previous morphology.
Absolutely. Just one suggestion. You know, I don't know if anyone or you, Jagdish, ever had an opportunity to use an extra backup right coronary catheter. It is XBRCA. It is just like Amplatz, but Amplatz has a terminal long beak. When you deploy or use XBRCA, it has the same curvature, very equivalent backup, but without damaging terminal tip. And I think it's a very good catheter for this kind of a case, where there is a CTO starting very proximally. And in my opinion, the polymer wire, like as you said, would not be likely to be very successful because now situation is very different. Yeah. Okay, Jagdish.
Dr. Kani wanted to make a comment.
That could be useful. We were discussing in the morning in CTO tips and traps that if you take a long sheath, 60 centimeter or even 45 centimeter long sheath, it makes the power of your guide catheter by one size up. 6 becomes 7 and 7 becomes 8. Yeah. Okay.
So this is where we
Wanted
started.
Dr. Kani.
That's unfortunately, but that would be an added dye load.
Second attempt on this patient.
No,
Yeah.
I think it would be safe to assume that we saw from the previous attempt that there was a flap, a dissection. The wire progressed only up to certain levels, say not more than, I would say, 12, 15 millimeter beyond the actual lesion. So it would be fair to assume that the total occlusion is likely to be not very long. And other than the length of the occlusion, CT would not have much role.
Would you consider using an intra-aortic balloon pump,
Yes.
Probably, yes.
Marco?
So for the CT scan, I would discourage you to do that because, as I said, the information will not be useful, and you have the downsize of the contrast. So in this patient, of course, that is already a very borderline. I would discourage you to use a CT scan.
Yeah.
The balloon pump is more depending. It's really, if he's in frank heart failure, then you may want to use it just to help you. And one other thing is that if the patient is really borderline, then maybe if required, you may consider intubating before and taking your time, because this is a long procedure where you will require dye, and you want to, if he's really borderline, you don't want to have him intubated emergently in the cath lab.
Okay.
In addition to the intra-aortic balloon pump, I would like to keep the Swan-Ganz catheter and have a close watch on the PA pressure. Okay. Because the ejection fraction is very low, and we are going to expect more of dye load and longer procedure time.
Okay. We start with this first, what we did. You can see that some channel and some flow is maintained. There are bridging collaterals.
That is the reason.
Play that again, please. Go back and play that again.
Which wire is this?
We chose a Crossit 200 XT. because we wanted to be somewhere in between, hard enough and not trying to go into the dissections. So we did not want us too much of a slippery wire. Go back, please. One slide back. One slide back. One slide back. Back, one back. Yeah, okay, display that again. Okay. This kind of a recording comes only if you have a fluorosave facility, because normally when you are wiring, you are on the fluoro. And if you have a fluorosave facility, in retrospect, you could. Otherwise, normally you would not seen a record of wiring of a lesion. Next, please. So we could get the wire actually, surprisingly for us, without too much difficulty. And the difficulties were not over so far. Next, please. Now, no balloon would cross. You name the balloon that was available on the shelf, and the smallest one, maybe 1.6, even that wouldn't cross. You can see that the guide that was used was a JR 3.5 centimeters. Next, please. It would back up every time the balloon tried to hit the lesion. Next, please. So they were desperate attempts to open up with the distal end of the balloon. Next. But obviously, we were not in the lesion at all. Any comments at this stage?
Did you try microcatheters?
No, we didn't try them.
Comments?
Maybe a microcatheter like to Corsair, for example, or really at the end, if nothing else works, maybe
Prograde.
Fine cross or something.
Yeah, fine cross or Corsair is even better than fine cross. Or Tornus at the end if really nothing works.
Corsair is midway between the Tornus and the fine cross. It has 2 stiff wires. It's 10 wires. And that certainly could work. I think it has
Which was the
easy
smallest
crossing.
balloon you tried?
1.1 balloon. So,
1.1 from Acrostech.
yes.
Wow, I want to tell you a few things. My experience is that crossability profile is not the only point which decides the success. The shaft and the strength of the balloon to be able to transmit. There has been instances where I have failed with Minitrack 1.2 and succeeded with Legend 1.25 or even Sprinter 1.5.
Yeah, that's because of the toughness of the balloon.
Yeah,
Shaft.
yeah. So that can be done in this case. And obtaining the support from the opposite aortic cusp by gradually deep seating, though the tip may not move. You have a 7 French catheter. 7 French?
Yes.
Yeah. So that could be the other option. Or a Tornus.
So at this stage, we thought the guide wasn't giving us enough support. So we decided to change the guide to Amplatz. Next, please.
Yeah. Did you change it over the wire or you removed the wire?
No, we don't, because we did not want to lose the axis at all. Next, please. I'll show you. Next, please. So here is the double length 35 coming there through the guide catheter. Next. And we pulled out the JR's catheter, and here is a double length 35. Next. And over this, leaving the coronary wire inside. Next, please. We get an Amplatz down. We did not extend the coronary, we just pushed it over it. Next, please. So now we have Amplatz in place, and we'll make some more attempts with more balloons. Next, please. Lot of difficulty still. Next. Next, please. Finally, I think, next, please. The balloon crossed. And
What balloon?
it was 1.25 sprinter. Next. And then the things were easier once we were across and got a dilatation. Next, please. We did some subsequent dilatations with bigger balloons. Next, please. Next, please. Next. The artery really opened up. Next, please. And then finally the stent, I think it was 3.533. Next, please. And that was the final result.
There are
Actually,
some
it is a-
collaterals
Explain
going to
that
the
again,
septal
please.
branches.
So this is actually exchanging the catheter with the wire in this C2O is a risky
Play that.
procedure. You may lose the axis. You could have used a mother and child technique with hot rail catheter for a backup support. Any other method could have adopted than exchanging the guiding again in this complex case.
Yes.
Any other method to get backup extra support, like a balloon anchoring technique or a mother and child technique, these things should have been adopted rather than going for a major
Yes.
exchange of the
We
wire
did
and all.
what we were most comfortable with.
No, mother and child technique would not work in this case.
Nor balloon
Mother
anchoring.
and child technique can give you a support if the lesion was in the mid segment. Here, your guide catheter was very close to the beginning of the CTO. So only a small half a centimeter of a child catheter would be going in. That is not enough. It is as good as the main catheter giving support. I don't think mother and child technique is a good idea for a very proximal lesions. Nor anchoring balloon. There is no vessel coming out proximally.
Excuse me, sir. Can we have used a
Second
body wire
wire
inside the
must have been
conus?
tried before taking out the catheter exchanging with.
Sorry, what should be?
Second wire. Must have taken the second wire and crossed for the
Second
second
wire.
wire. And then
Buddy
might
wire.
have
To
tried
give a buddy wire
technique.
to give
Yeah.
a backup
Yeah, might have
support.
been a better.
Buddy wire could have been a
That
possibility.
could
Yes.
be a possible
Yes.
strategy, yeah.
A buddy wire in the conus for a better support.
No,
And
even, not in a conus. We have to cross like
No.
that. First we wire crossed and then
All the
we'll
way,
cross
yeah, all
again
the
when
way.
I give the
Crossing.
PD or something in the
All the way
another-
parallel.
Yeah.
Parallel
Parallel
buddy
and
wire.
we'll give a
That is the
take a
only.
better support
That
and
is
then we'll
probably
fill
the
up.
only option you had, other than changing the guiding cath. And I think people who have done this before is not such a difficult thing,
Yes.
and that he has demonstrated very well. That it is possible to change the guiding catheter on a coronary guide wire
What-
with the help of 035 exchange length wire, and it's
Right, I think just only one technical hint. In case if the wire loops into the ascending aorta, do not try to do unlooping by pulling the wire. Instead, the whole assembly, including the two wires, 0.035, and your guide wire, coronary guide wire, along with your catheter, should be pulled together till the loop is undone. That's, I thought, was worth.
And sir,
Bringing
I
out.
think XB would have been even easier to
absolutely,
guide in.
absolutely.
If the balloon would have not crossed, I think the next step would be to use a turnus. What about your experience with turnus? Would have been we had a similar situation where I used a
Certainly.
turnus and then
Yeah,
we
Yeah.
got it.
Yeah.
tonus or
From
crosser,
the
as
outside,
Marco said.
from the outside, we must have tried with the
Corset.
amplazer because the previous one tried the amplaz. We must have learned the lesion, and instead of taking and exchanging the wire, we must have taken some lesion from the
Amplas
previous.
had traumatized.
Yeah, could have.
Amplas traumatized the vessel, so that's why they want to be
But
cautious.
equally important, the proximal vessel is the support, which we usually expect less with the JR catheter.
But there are many strategies to do a thing, and then they wanted to go cautiously. They used JR4
True,
and then
because
shifted over to
that
Amplas.
strategy has failed, so obviously we had to try something else.
We I think, time to say consensus. I think because they want a live transmission in another 5 minutes. So I just think, opening a CTO of this kind is really very challenging because an acute event took place on top of chronic, and unfortunately there were no collaterals in this case to protect that territory. So this really was a challenge, and I think the doing a case like this, there are many strategies involved, but basically this is one reason why I've been always emphasizing that please don't use 6 French catheter, because you will be required to use many. And apart from supplying several things, like it gives a bigger body, therefore a bigger power, it may permit you to do things like buddy wire, as was pointed out, or you may want to use a sort of any form of support, use a turnus and whatnot, and many exchanges, so you could do that. And I think in this kind of a patient, the opening a CTO is very, very rewarding. And I think time is up now, and we'll have to say, and I wish to take this opportunity to thank Dr. Marco Raffi, you, and Dr. Samir Dani and the audience. Thank you very much.
Thank you. Thank you.